Good afternoon, everyone. My name is Sergio Navarrete, and I will be presenting on extracorporeal membrane oxygenation, otherwise known as ECMO, for COVID-19 patients. In this presentation, I'll focus on veno-veno ECMO for respiratory failure. As many of you know, there is veno-arterial ECMO that is often for shock or cardiogenic failure. So I have no conflicts or relevant disclosures. The objectives of this presentation are the following. We will briefly review the COVID-19 known pathophysiology to explain why ECMO may be relevant. Then we will discuss the basic idea behind ECMO cannulation strategies. We will look at ECMO criteria for COVID-19 patients. And then we'll review some basic ECMO management. And finally, we'll look at the data for survival of ECMO patients so far in the COVID group of patients. So the SARS-CoV-2 virus is an enveloped RNA virus which causes the clinical syndrome of COVID-19. The coronavirus, primarily a respiratory pathogen, is thought to invade by interaction of the spike protein with the ACE2 receptors on host cells. There are ACE2 receptors throughout the body, including the lungs, heart, renal system, genitourinary system, and the brain, with a specific concern for a high concentration of receptors in the thalamus and brainstem, which has been demonstrated in the similar SARS-CoV-1 and MERS viruses that are similar to the SARS-CoV-2 virus. Initial symptoms of the SARS-CoV-2 virus COVID-19 syndrome are flu-like illness with a sore throat and fever, and in most patients is very mild, but may progress to an acute hypoxemic respiratory failure. Patients often present with high fevers, tachypnea, and hypoxemia. Hypoxemia is initially responsive to supplemental oxygen, but a subset of patients rapidly progress to high FiO2 requirements and need for mechanical ventilation. Reported complications of COVID-19 infections include septic-like distributive shock, acute kidney injury, hypercoagulable state, and cardiac arrhythmias with cardiomyopathy of various proposed etiologies. Viral cardiomyopathy is one of them. Unfortunately, when severe, the disease has a high mortality of approximately 50% in patients that are in the ICU. The disease state often lasts more than 10 days and requires intensive care management of primarily mechanical ventilation, vasopressor titration, and renal replacement therapy. As many of you know, two distinct phenotypes of respiratory mechanics are seen, recently described by Gadenoni. He published a paper very recently which described two primary phenotypes based on the interaction of the following factors. The type L phenotype, which is characterized by low elastance, low ventilator perfusion, low lung weight, and low recruitability. And the type H, which is characterized by high elastance, high right to left shunt, high lung weight, and high recruitability. It is unknown if the natural progression of disease leads from the first to the second phenotype, or if self-inflicted lung injury, superinfections, and iatrogenesis of ventilator-induced lung injury are the culprit. A subset of these severely ill patients are unable to be oxygenated or ventilated, even with prone position and muscle relaxation, which are standard of care. This subset is postulated to benefit from veno-venous extracorporeal membrane oxygenation. Another yet smaller population of patients may benefit from veno-arterial ECMO are those with associated cardiomyopathy or maybe an acute pulmonary embolism. Before continuing further into the conversation of ECMO for COVID-19 patients, I would like to briefly cover the major literature surrounding ECMO for respiratory failure. So we'll cover just a very brief history, then we'll talk about the CSER trial that was conducted between 2001 and 2006 and then published in 2009. We'll talk about the H1N1 influenza pandemic and how it affected ECMO. And then we'll talk about the Aiolia trial published more recently, and then how types of respiratory failure have different survival and how the literature has been dealing with that. So ELSO was established in 1989 in the United States and is the major society for ECMO and provides most of the recent guidance for ECMO-related COVID-19 support. ECMO is a relatively new supportive modality introduced for clinical use in the 1970s for neonates in respiratory failure. The technology was adapted for adult ECMO, and it gained traction toward the late 1990s. By 1999, there was an ELSA meeting to set up a randomized trial, which was carried out between 2001 and 2006. So these images, I just wanted to kind of introduce ECMO as a whole for some of you that may not be familiar with it. Basically, the diagrams are from a very recent publication by Gattinoni and his colleagues in 2020 in Anesthesiology, and then a very good narrative review in the New England Journal from Brody and Bachetta from 2011. On the left, you can see a simplistic representation of veno-veno ECMO. The blood is drained by a centripetal pump to the oxygenator and ventilator, actually, I guess to the oxygenator ventilator, and returned to the heart via a second cannula. The extracorporeal membrane both oxygenates and removes CO2. Here you can see two of the three main VV-ECMO cannulation strategies. The leftmost image is a femoral internal jugular strategy, and the image to its right, directly to the right of it, is a dual lumen cannula strategy with an inflow in the SVC and IVC and an outflow directed toward the tricuspid valve. The third strategy is a femoral cannulation with one caudad drainage cannula, usually positioned below the IVC, and one cannula in a more cephalad position near the cable atrial junction, returning the blood after it's been oxygenated. On the bottom right, you can see the membrane dividing the gas flow and blood within the oxygenator. And then the graph to the top right shows you the progression in ECMO use throughout the last 30 years. As you can see, utilization of ECMO for adult respiratory and cardiac failure has increased significantly and now makes up more than 50% of extracorporeal life support. A recent publication by Ramathan et al. In 2020, basically the planning and provision of ECMO services for severe ARDS during the COVID-19 pandemic and other outbreaks, discussed available evidence for similar patient populations such as the H1N1 and suggests that carefully selected patients with severe ARDS from COVID-19 who don't benefit from conventional treatment might successfully be supported with veno-veno ECMO. This image is actually from that paper. On the left here, you can see that around 2009, during the H1N1 pandemic, is where you start seeing a higher adoption and growth in the amount of centers that are using ECMO for support. Despite its increasing availability, clearly ECMO is a limited resource that needs to be allocated to patients with the highest chance of survival. So let's review the CSER study by Peake et al., published in The Lancet in 2009. The study was entitled The Efficacy and Economic Assessment of Conventional Ventilatory Support versus Extracorporeal Membrane Oxygenation for Severe Adult Respiratory Failure. It was a single center study in the UK. Randomized controlled trial ran from 2001 to 2006. The clinical question was if the extracorporeal membrane oxygenation was a safe, efficacious, and cost-effective treatment compared to the conventional treatment for management of severe adult respiratory failure. It was randomized to conventional ventilation versus transfer to an ECMO specialty center for consideration of ECMO. 24% of the patients who were randomized for ECMO never received it. They either died or were rescued without ECMO. Or they died prior to ECMO, is what I'm trying to say. So death or severe disability at 6 months was after randomization was the primary outcome. And the survival free of disability was 63% in the ECMO referral population and 47% in the conventional ventilation group, with a p-value of 0.03 and a number needed to treat 7. The image here on the right shows that Kaplan-Meier survival curve that very clearly separates quite early. The criticism of this study is that it evaluated a single specialist center versus other non-referral hospitals. Another main and important criticism is that the control group, only 70% of patients received lung protective ventilation versus 93% of the intervention group. So in comes the H1 influenza pandemic. We can learn much about ECMO from the H1N1 pandemic. Although the majority of patients during the 2009 pandemic were young adults, the viral pneumonia associated with this disease was severe, leading to almost 30% ECMO utilization in the Australia, New Zealand population, and was reported in the 2009 observational study by APRA et al. H1N1 selected young adults, and thus most patients requiring ECMO were less comorbid than the typical ARDS patient. The majority of patients had single organ disease, and despite long ICU and hospital stays, had an excellent survival. The survival for the observational study by April was 79%. A follow-up meta-analysis published in 2013 by Sergio et al. Examined 8 registry studies for H1N1 patients, encompassing a total of 266 patients who were affected by H1N1, with an average age of 36. Patients who received mechanical ventilation before ECMO implementation for a median of 2 days were transferred to referral centers in 72% of cases, and mostly 94% had a veno-veno ECMO implanted. ECMO was operated for a median of 10 days, with short-term mortality ranging between 8 and 65%, with a median intensive care unit stay of 25 days and an overall median total length of stay of 37 days. The H1N1 pandemic, as you saw in the prior image, led to a wider adoption of ECMO throughout the world. The reason I brought this specific image up is because it's very similar to what we're seeing currently with our COVID-19 patients. Also, the course of disease is quite long in the H1N1 pandemic, as we are seeing as well with the COVID-19 patients. So I'd like to cover a little bit about the extracorporeal membrane oxygenation for severe acute respiratory distress syndrome, the Aiolia study by Combs in 2018, published in the New England Journal. The trial was a follow-up to address many concerns over the validity of the CAESAR trial. The main concern was the CAESAR trial was a single center study where patients were referred to for a refractory hypoxemia, but not all patients received ECMO. Thus, the trial showed improved outcomes by treatment at a referral center and not necessarily from ECMO itself. The Aiolia trial was a prospective multi-center randomized control trial at 64 centers, primarily in France, to answer the question of, in patients with severe ARDS, does early initiation of ECMO compared to the standard care improve mortality at 60 days? The control group received standard of care lung protective ventilation at 6 mils per kilo, and a PEEP set so as not to exceed a plateau pressure of 28 to 30. Prone positioning, muscle relaxation, bicarb infusions, and pulmonary vasodilators as adjuncts were all permitted. The treatment arm was VV-ECMO for patients with a PF ratio less than 150 for more than 3 hours, or less than 80 for more than 6 hours. Or a pH less than 7.25 for greater than 6 hours. Despite standard of care. Cannulation was a femoral drainage with a right IJ return cannula. Crossover in the study was permitted, and it was reported to be quite high at 28%. The study suffered from this because the analysis was done as an intention to treat, thus making the results much more difficult to interpret and introducing sicker patients into the ECMO group and leaving healthier patients in the control group. The mortality at day 60 was approximately 35% in the ECMO group and 46% in the control group, but was not statistically significant with a p-value of 0.09. The Kaplan-Meier survival curve that you see on the right of the screen shows the separation early by day 10. However, the crux of this trial was the use of power calculation based on a 60% expected mortality in the control group and a 20% absolute risk reduction. These, in retrospect, were over-enthusiastic assumptions. The trial was stopped early for futility, and the conclusions that may be drawn from this trial is that standard therapy had a high rate of failure, leading to ECMO utilization, and that there is possible benefit from ECMO over standard of care, especially if used early rather than late. So respiratory failure and survival. Schmidt et al. From the ANZIX group developed a calculator basically to to calculate the probability of survival based on several variables. It evaluated 2,300 VV-ECMO runs and applied a multivariate regression analysis to create a scoring system to evaluate survival with a 90% confidence. While ECMO can be used for multiple types of respiratory failure, survival differs depending on etiology. In single organ disease, well-selected patients have the highest survival with asthma and aspiration pneumonitis, followed by viral and bacterial pneumonias, and the lowest survival is with other reasons for ARDS, such as pancreatitis-induced ARDS. Comorbid conditions and age are major contributors to poor outcomes, and then pharmacologic immunosuppression increases mortality in ECMO patients and is often considered a contraindication. The severity of respiratory failure and associated interventions usually increase mortality, with the exception of neuromuscular blockade. Here I've included a couple screenshots from the REST score. It's REST score. Here's another just example of how just having asthma and VV-ECMO for asthma actually carries a quite high survival. And just as a side note, there's also such a thing as the SAVE score, which is used to calculate survival for VA-ECMO. So the general criteria that also has given us, or I guess indications and contraindications, are the following. Indications are to consider when the risk of mortality from respiratory failure is greater than 50%, and then indicated when the risk of mortality is greater than 80%. This would be in patients with CO2 retention and plateau pressures greater than 30, severe air leak syndromes, immediate respiratory collapse, like a blocked airway, which is unresponsive to usual care, and need for intubation of a patient on the lung transplant list. Some of the relative contraindications are high mechanical ventilation settings for more than 7 days, major immunosuppression, central nervous system hemorrhage, non-recoverable comorbid terminal malignancies or CNS damage, and age. Although no specific age cutoff exists, advanced age has significantly lower survival. So initially, I also put out a guidance document, which included this flow diagram that I've included here. The document used the indication and contraindications that are used normally. The basic premise of the document was to say that ECMO should be considered for COVID-19 patients and traditional ECMO indications, with the exception of ECPR for COVID-19 patients. They also released a statement on the definition of futility in these patients. And they basically said that during times of limited resources, a patient that's not recovering after 21 days on ECMO, it can be considered to be futile. So during that interim time between early February and later in March, a few other institutions and societies published their own protocols for COVID-19. The one on the right is actually from Sam Galbano, who published this on the ASA website and is also supported by the Society of Critical Care and the SOCA. Basically, it's the same criteria that I just mentioned, but given that acute renal failure is so common in the COVID-19 patients, they did not include acute renal failure as part of the exclusion or contraindication criteria. And then I'd like to point out MGH as well put out their very concise ECMO protocol for the COVID-19 patients. And some of the things that I thought were interesting is they specifically noted femoral jugular cannulation to eliminate need for guided imaging, and that ECPR patients would not be considered. So since that initial guidance document also released interim guidelines for ECMO centers and providers. The recommendations include equipment simplification, patient selection, cannulation strategies, general management, and weaning. I will cover simplification and patient selection on this slide. It is recommended that staffing be maintained at a 1-to-1 nurse-to-patient ratio rather, and to have a 2-to-1 ECMO perfusionist ratio to maximize patient safety. The redeployment of RVAD devices coupled with membrane lungs could increase the availability of devices, and the FDA has also issued guidance on the use of bypass devices adapted for ECMO therapy in a public health emergency. Finally, the shelf life of prime circuits can be extended to 60 days as long as no glucose-containing solutions have been used and sterile standard technique is followed. As far as patient selection during the COVID pandemic, as resources become more scarce during the pandemic, triage becomes more stringent to offer ECMO only to patients with the highest likelihood of survival. The diagram on the right of the screen is a proposed tier system for ECMO allocation that basically becomes more stringent as resources become more scarce. Finally, I just wanted to mention for weaning and decannulation, basically it should proceed as per normal guidelines for the non-COVID-19 patients, with the exception of careful and appropriate PPE per institutional and regional guidelines. So as mentioned previously, there are several cannulation strategies, of which the two recommended approaches are represented on the right. The femoral-femoral or the femoral internal jugular configuration can be used. The femoral-femoral approach allows for more rapid surgical field preparation, creates efficiency in movement around the bed, and keeps the operator away from the patient's airway. A large multi-stage drainage cannula and a single return cannula are what has been proposed as most effective. The dual lumen cannula should be avoided if possible, as they take longer to insert. They're usually associated with higher risk of thrombotic complications and malpositioning requiring repeat echocardiography with associated increase in resource utilization and personnel exposure. So this is actually from that guideline paper published by ELSO. I'm not going to have you guys read this, but I will hit the main points on it. So per the ELSO guidelines, continuous monitoring of pre and post membrane gas and transmembrane pressures is necessary, at least daily blood gases, and then frequent circuit and device checks for clot are necessary. A prime circuit for emergent exchange should always be available. For procedurals surrounding this patient, they should be clustered and minimized to decrease staff exposure. And then cautious percutaneous trach is the preferred method to be considered on a case-to-case basis. Imaging studies should be limited and used mainly at the bedside. CT only to be considered if it will change management. They advocate for ultrasound and bedside x-rays. Therapeutic drugs, they basically said that none of them are really recommended at this time to treat COVID-19. There is a recommendation for use of extracorporeal cytokine hemoadsorption and possible use of steroids if indicated for septic shock. From a hematologic perspective, they suggest a hemoglobin of 7 to 8 grams per deciliter, platelets greater than 50,000, and fibrinogen greater than 100. The use of anticoagulation should be guided by institutional protocols. And here at Johns Hopkins, we use a low goal heparin drip for our anticoagulation. From a GI standpoint, early enteral nutrition is necessary, and the guidelines suggest avoiding prolonged nutrition deficits. And finally, one thing that I thought was interesting from a mobilization standpoint, they suggested that patients who have COVID-19 are unlikely it would be unlikely feasible and has no clear benefit or definite risks for sure. They also advocated for early splinting and in-bed PT maneuvers. From a respiratory standpoint, I would like to kind of cover a couple things. First of all, permissive hypoxemia, which has some data, although it's mostly observational and retrospective. So also guidelines suggest a goal saturation of greater than 80% as long as the pre-pump venous saturation is 70%. A direct quote from ELSO guidelines is that in the absence of lung function, VV access can supply all the metabolic oxygen requirements. The arterial saturation is usually 80 to 85%, but maybe 75 to 80%. The lower recirculation with the 3 cannula or double lumen VV approach results in higher saturations of 85 to 92%. This is ample oxyhemoglobin saturation for normal systemic oxygen delivery, as long as the cardiac output and hemoglobin concentration are adequate to maintain delivery of oxygen 3 times the oxygen consumption. However, ICU staff may be uncomfortable with arterial saturations under 90%, and education regarding oxygen delivery is important. Avoid temptation to turn up the ventilator settings or FiO2 above the rest settings during VV support. That's their direct quote, and there is some data to suggest that that is safe. A small single center study by Hudsgraf et al. Investigated cognitive outcomes in survivors of ECMO. Basically, cognitive, memory, and MRI studies were done in survivors 3 years post-ECMO, showing similar scores compared to the rest of the population, and no hypoxemia-related changes on MRI. Many of this cohort had prolonged periods of O2 saturation of less than 80%, with an average O2 saturation during their ECMO run in that cohort of 80%. A larger follow-up single center study from the same group is the image shown here on the right. Basically, what you can see is patients that were hypoxemic on ECMO did just as well or better than patients that were not hypoxemic on ECMO. And then the images to the bottom are patients that were hypoxemic and had brain lesions such as strokes, ischemic strokes, or hemorrhagic strokes, compared to patients that were not hypoxemic during ECMO that also had brain lesions. This was a larger study. I didn't write down how many patients, and I don't remember at this time, but I have included the citation. It's the study by Bonvar et al. At 2018. So this is an important point because hypoxemia often makes bedside providers nervous and may lead to interventions that put patients at risk for complications. Interventions may range in complexity and propensity for iatrogenesis, but could include cannula advancement leading to bloodstream infections or drastic measures such as placing a second cannula. So the counterbalancing argument to hypoxemia being safe for patients was made by Munshi et al. In 2017, which showed that patients with a PaO2 less than 60 on VV-ECMO had a higher mortality. This was an association based on a retrospective study. Per ELSO, the goals would be a SpO2 of greater than 80%, a central venous O2 of greater than 70%, and to optimize delivery of oxygen via other methods, such as maybe increasing the hemoglobin. So what about evidence regarding ventilation targets on VV-ECMO? The overall goal is to protect the lungs from ventilator-induced lung injury as much as possible. VV-ECMO should allow you to decrease tidal volumes, plateau pressure, PEEP, and driving pressure. This was shown by the Lifeguard study, which was an international multi-center prospective cohort mechanical ventilation during ECMO for ARDS. The mechanical power applied by the ventilator on the lungs causes injury. We know this. Driving pressure appears to be a variable most associated with mortality in ARDS. Ideally, during VV-ECMO, supported by the available literature, targeting a plateau pressure of 24 or less, a driving pressure of 14 or lower, and a tidal volume of 4 mils per kilo with a respiratory rate of 10 or lower is ideal. This can be achieved by setting a pressure control mode with pressure of 10, respiratory rate of 10, PEEP of 10, and FiO2 of 30 to 50%, which is done routinely here at Johns Hopkins. So I just wanted to kind of show the basic parameters on the VV-ECMO circuit. So on the leftmost of the screen, you can see 3000, that's the speed or RPMs. The flow is next to that, 4.04. And then on the right of that, there's 3 dials that might be difficult to see, but I'll try to point them out. The first 2 are to dial in sweep or flow of gas through the membrane. And then the one furthest to the right is used to dial in the fraction of inspired oxygen. So it's a mixer of air and oxygen. So I just wanted to go through a couple things for some of the residents and people that are in the ECMO unit, I wanted to go over some troubleshooting and complications. Some of the main things that you will see with VV-ECMO patients are positional issues with cannula, especially the double lumen IJ cannula. This requires sometimes gentle manipulation of head position or repositioning via echo guidance, typically transesophageal echo. The other thing is you can see when initially you have an ARDS patient, we tend to run these patients dry. But once they go on to the ECMO circuit, they may require some additional volume. When you see patients that are dry at baseline prior to going on to the ECMO circuit, you will often see something referred to as chatter, where the drainage cannula has intermittent flow due to collapse of the drainage cannula to the walls of the vessels, usually the IVC. This can be remedied by giving aliquots of fluid resuscitation or decreasing the pump speed. A reminder here is that speed is adjusted and flow is measured. In some cases, cannula malposition will also cause chatter or the appearance of chatter. You will see sometimes recirculation of flow within the ECMO circuit. This phenomenon is seen when the flow is partially or preferentially goes from the return cannula to the drainage cannula instead of return cannula to the patient's systemic circulation. This is seen more commonly in the femoral IJ cannulation strategy and may require repositioning of the cannula or decreased flow. If your flow is limited compared to your cardiac output, you will only generate a portion. You will only oxygenate a portion of your flow. This is sometimes referred to as an intrapulmonary shunt. And strategies to increase the strategy to fix this is to increase pump flow as possible, or to reduce cardiac output if appropriate. Finally, some of the most common things are thrombocytopenia and hemolysis, which can be problematic. Therefore, we monitor LDH and platelet counts. And then as flow increases, shearing forces damage blood cells. If possible, the first mitigating step is to reduce pump speed. And then clotting is one of the most feared complications of patients on ECMO. Often small clot and fibrin deposits will be seen on the lower flow segments or turbulent branch points of the circuit, especially at the oxygenator membrane. Because of this, it is recommended to use anticoagulation to reduce the activation of the coagulation cascade when the blood comes into contact with the circuit. Circuits have improved substantially, and VV-ECMO can often be run without anticoagulation as long as the flow is maintained to avoid stasis. So bleeding related to thrombocytopenia, DIC, or anticoagulation are all often seen and may require temporary discontinuation of anticoagulation. And in ICU-related infections, including line cannula infections, are possible. All right, so there is a study that is currently underway to evaluate whether ECMO is helpful more objectively in our COVID-19 patients. This is called the ECMO card study, of which there are centers throughout the world, including Columbia University, Barcelona, Spain, throughout Europe and Asia as well. And fortunately for now, we have some preliminary data. As of last night, 487 COVID positive or suspected patients have been supported or are being supported with ECMO. Of the ECMO runs, 91% are VV-ECMO. 198 patients have completed their ECMO run with an average of 190 hours on pump. The major reported complications are intracranial hemorrhage and renal failure. Of those patients that have completed their ECMO run, 87 are still in the hospital, and 36 patients have been discharged alive out of 19 patients that have been discharged from the hospital. The survival of the patients discharged is approximately 40%. So currently at Johns Hopkins, we are under review of our guidelines for ECMO in the COVID-19 pandemic. I've included at the end of my presentation here just what we are currently following. I'm not going to necessarily go over it because it's very specific to our institution, but I will include it in our slides here.